We're good?
You're good.
Okay. So I'm Kucey. I'm one of the antimicrobial stewardship pharmacists here in Regina, and was supposed to be joined by my colleague Kristin Schmidt, but unfortunately she has a pretty nasty cold, and so she's not taking antibiotics for, I will say. So she had messaged this morning and said, I got to tap out of this presentation. So bear with me. I had about 40 minutes to kind of prep and go over her slides. So I'm going to talk about all of the fun antimicrobial stewardship initiatives we got going on in Regina acute care centers to maybe give you some ideas of initiatives you could implement in your own facility, or maybe just to be aware of some of the great stuff we have going on in Regina. So I'll start by going over our vision, mission, values, and philosophies of care of Saskatchewan Health Authority. Antimicrobial stewardship definitely touches on a lot of these, but for sure touches on the overall vision and mission, and that's to work together collaboratively with multiple stakeholders to improve the health and well-being of our patients every day for everyone. Antimicrobial stewardship obviously aims to optimize antimicrobial prescribing to reduce antimicrobial resistance and improve patient outcomes. I would also like to take a moment to acknowledge that we are gathering on Treaties 4 and 6 territories in the homeland of Dakota, Lakota, and Métis. Recognizing this history is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples. It's also important just to take a moment to think about and reflect on what truth and reconciliation means to you. Okay, the outline for today's presentation. So I'm going to talk about the importance of antimicrobial stewardship. Why are we doing all of this stuff? Why does it matter? I'll talk about penicillin allergy delabeling, and then I'll talk about all of the stewardship initiatives we've got going on in ICU because we've got a lot of them. So we do procalcitonin testing, we do MRSA nasal swabs, and we have started antimicrobial stewardship rounds once weekly. So we'll touch on all of those things. So why does all of this matter? Why is antimicrobial stewardship so important? We know that antimicrobial resistance is one of the leading causes of death worldwide. And in fact, currently we see about 1.3 million deaths per year due to antimicrobial resistant infections. Now, based on prediction models, it is estimated that by 2050, that number is expected to rise to 10 million deaths per year due to antimicrobial resistant infections. Now, to put that in perspective, currently we see about 10 million deaths per year due to cancer. So what that means is, well, within our lifetime, within the next 25 years, we'll see as many people dying from antimicrobial resistant infections as we currently see dying from cancer. So that's a very sobering statistic. And just to highlight the fact that this is already here, this was a culture and sensitivity report of a patient that I was involved with about 2 weeks ago. So this patient grew a club pneumo from their urine. That was the most resistant organism I've seen in my career. This club pneumo was pan-resistant to all of the agents we had available to us in Canada. We then requested to the lab to send off extended susceptibilities to other agents available in the States, and all of those came back pan-resistant. So this club pneumo was resistant to absolutely every antibiotic that we could think of that could possibly treat it. So we had essentially no options to treat this patient. And unfortunately, that is the very terrifying reality of antimicrobial resistance, and that is what we are very much trying to prevent. So one of the initiatives that we implemented to try and optimize our antimicrobial prescribing is around penicillin allergy delabeling. So quick bit of background, penicillin allergies are commonly reported. In fact, about 10% of the population report having an allergy to penicillin. But the reality is less than 1% of the population are truly allergic to penicillin. So the vast majority of patients who think they have an allergy can actually safely take penicillins. And studies show us that in patients who report an allergy to penicillin, they're far more likely to get exposed to more broad spectrum antibiotics. And that increases the risk of adverse events. It increases the risk of C. diff, increases the risk of surgical site infections, MRSA, and VRE infections. So we know that in patients who report having an allergy to penicillin, they're more likely to be put on a broad spectrum antibiotic and more likely to experience some sort of harm associated with that, which also means increased cost to the healthcare system. So if we know that most patients who report an allergy are not truly allergic and can actually safely take penicillins, the most important thing we can do as clinicians is to reassess these allergies And there are very helpful tools out there that exist that can guide with that assessment. The one that I'm going to talk about today and the one that we incorporate in our practice is on First Line. Now, First Line is an ID resource. It's a website or an app that you can download. It has all of our local practice guidelines on it. It has all of our local antibiogram information, and then it also has some really helpful resources and tools. One of these helpful resources and tools is the penicillin allergy delabeling tool. Now, this tool is a fantastic tool. It's a point of care risk assessment tool. So basically, it walks you through step by step the question that you would ask your patient when you're reassessing a penicillin allergy. And it takes maybe 1 or 2 minutes to do. At the end of those questions, it will risk stratify the patient for you and tell you if this patient is very low risk of having a penicillin allergy, and if they are eligible to be delabeled. If the patient is more moderate to high risk, it will flag that person as having a possible allergy and then stop you there and just say, refer on to an allergist for further reassessment. So this tool is very helpful in identifying our low-hanging fruit and our patients who are low risk and can be delabeled. So Kristin and I created a work standard around this, how to identify patients, reporting a penicillin allergy, going through the process of assessing that allergy and the process of delabeling them. And this is an initiative that we've incorporated into our pharmacy student rotations. So we will go through this penicillin allergy assessment and delabeling with our pharmacy students who rotate through. And once the students get comfortable with the process, then we let them fly and be free, and they will go and reassess penicillin allergies for us. So this is very much, it's become a student-led initiative within our department, which is fantastic. I think it's a great way to utilize our students. And when we have delabeled a patient with delabeled their penicillin allergy, then we have outcome forms that we send out. So on the left-hand side, we have a patient outcome form that we would go through, and we would go through with the patient and we would send home with them. And then on the right-hand side is the healthcare provider outcome form. So we would fill this out and then we would fax this form to the patient's primary care provider or their community pharmacy so that they're aware that we've delabeled their penicillin allergy, and then they could update their records. And then we track all of this that we've been doing, and so we track all this information on REDCap. And this is probably an underestimation, truthfully. We try and track all of our interventions, but maybe don't have 100% accuracy with that. But so far, we have assessed 59 penicillin allergies. Of those 59 allergies, 40 of them were deemed to be low risk and would be eligible for delabeling. Now, of those very low risk patients, we delabeled 88% of them. The vast majority of those delabeled were delabeled based on history alone. And then we had about 25 to 30% of them that we actually delabeled by applying an amoxicillin test dose challenge. And all of those patients who had a test dose challenge tolerated it fine with no concerns. So now we're going to switch gears and talk about antimicrobial stewardship in the ICU and all of the initiatives we got going on there. So we submit, before I dive into the initiatives, I guess a bit of background. So we submit our antimicrobial use data to the Canadian Nosocomial Infection Surveillance Program. Now, this is a national surveillance program. And at the end of the year, they'll send us an annual report back that shows us how our antimicrobial use compares to other participating centers across Canada. So very helpful for benchmarking purposes and maybe identifying areas for improvement. If you look at the graph that I have at the bottom of the page there on the left-hand side, that is showing you our antimicrobial use in our ICU, and specifically our data is represented by the red dotted line on that graph, which hovers above the bars within that graph. And the bars in that graph represent the antimicrobial use of other participating centers across Canada. So as you can see, our Regina ICUs use considerably more antibiotics or antimicrobials than other participating hospitals across Canada. And specifically in 2022, we use about 60 to 70% more antibiotics than other participating hospitals. So that was obviously very concerning and something that we wanted to address. So we were looking at what initiatives could we implement in the ICU that could reduce our antibiotic prescribing. And the first thing we implemented was procalcitonin testing. Now, for those of you who don't know, procalcitonin is an inflammatory biomarker that is very, very specific for bacterial infection. In fact, it's far more specific than WBCs or CRP. So fantastic biomarker. Procalcitonin has favorable kinetics. It correlates with severity of illness, and we can use it to guide our antibiotic use and guide discontinuation. It can even be used to guide initiation in certain populations. So it's a fantastic tool to have access to. And when you look at some of the guideline recommendations, so specifically the 2021 Surviving Sepsis Guidelines and the 2016 IDSA Guidelines on implementing an antimicrobial stewardship program, they both suggest using procalcitonin to guide discontinuation of antibiotics and help decrease antibiotic use. And if you further dive into the literature around procalcitonin, there are a lot of randomized control trials showing that this is really effective. And specifically, if you look at sepsis or critically ill patients, there's many randomized control trials and even systematic reviews and meta-analysis, all showing that procalcitonin can safely decrease antibiotic use and actually improve patient outcomes. So I'm not going to go over all of the studies, but the one that I do want to touch on, because it's the one that very much influenced our clinical practice within ICU, is the SAPS trial. So this was a prospective, multi-center, randomized controlled trial conducted in the Netherlands. The Netherlands is one of the best users of antimicrobials in the world, far better than Canada and the States. So in this trial, the population that they looked at were adult patients admitted to ICU on an antibiotic for a suspected or proven bacterial infection. The intervention was a procalcitonin protocol to guide discontinuation of antibiotics, and then they compared that to the standard of care. The outcomes that they were looking at was antibiotic consumption and mortality. And what they found in this study was that in patients in the procalcitonin group, we significantly reduced their antibiotic use. We went from a treatment duration of 7 days, which was the standard of care group, which was already pretty impressive, down to 5 days in the procalcitonin group. So we're able to reduce that treatment duration by 2 days, which was phenomenal. But in addition to that, what they found was that in patients in the procalcitonin group, they had statistically significant lower 28-day mortalities and lower 1-year mortalities. And this was proven both in the intention to treat and per protocol analysis. And that gave us numbers needed to treat of less than 20. So that was a pretty remarkable finding and pretty profound. So we wanted to use procalcitonin in our ICU to reduce antibiotic use, possibly even improve patient outcomes, but we didn't have access to it at the time. So we actually had to put forward a business case to SHA executive leadership to get approval to start using the test in our facilities. So we needed to get stakeholder support. We needed to make sure we had the equipment and the lab capabilities. Cost was a consideration, and actually it wasn't as costly as we thought it was. So that's fantastic. The turnaround time was about 2 hours, so that was fantastic. We drafted up this business case, and this was input from many stakeholders who worked on this together. We submitted that to SHA executive leadership and thankfully received approval to start using the test. So we restricted the test to ICU, and the reason for that is there was a lot of consideration around diagnostic stewardship. Education with this test is very important to ensure that it's being used appropriately and interpreted appropriately. And it's far easier to do education to a smaller group of clinicians and do the data collection to a smaller group of clinicians than it is a whole hospital. So that was part of the reason why we restricted it. The protocol that we used was the same protocol that was used in the SAPS trial, so we didn't reinvent any wheels. It applied to adult patients in the ICU on an antibiotic for a suspected or confirmed infection. Assuming they didn't meet any exclusion criteria, we would be doing daily procalcitonin levels. And once they met a stopping criteria, so there was 2 stopping criteria. So either we saw a procalcitonin decrease by at least 80% from its peak value, or a procalcitonin level of 0.5 or less. If there was clinical improvement and they met a stopping criteria, we would recommend stopping antibiotics. There was a lot of effort to provide many educational opportunities, and so we had created presentations, presented at ICU grand rounds, tried to get in front of all of the intensivists, the CCAs, pharmacists, nursing, even the unit clerks, microbiologists, ID physicians, you name it. So multiple presentations were held. We even did one-on-ones with the intensivists that didn't show up to the education sessions. We created posters, sent out memos, so it was a huge attempt around education. And then we launched in October of 2023. And then we collected data. So we collected data 1 year pre-implementation and 1 year post-implementation. And what we saw is 1 year after implementing procalcitonin, we used about 2 to 3 tests per patient. We had a lot of variability in intensivist utilization. So, excuse me, on one end of the spectrum, we have, 1 or 2 intensivists who rarely ever use procalcitonin. They'll order it once or twice, and they don't always order it appropriately. And then we have 1 or 2 intensivists on the other end of the spectrum that very much have incorporated this into their clinical practice. They'll follow the protocol, they'll trend the levels, they'll stop antibiotics when it indicates it's safe to do so. And then we have the other intensivists that fall somewhere in the middle. So maybe they'll order procalcitonin and trend the level, but then they don't always respond to it when it tells them or when it indicates that it's safe to stop antibiotics. We looked at protocol adherence within 48 hours of meeting a stopping criteria, and that was about 62%. We were very generous with our 48-hour window. And obviously, this reflects the physicians that are actually using procalcitonin. And we haven't seen a reduction in our antibiotic use yet. So when we were going through our data and trying to understand our data a little bit, for us, it really wasn't a question of, does this test work? We know this test works. There's tons of evidence out there showing that it works. And in fact, there are published studies that looked at real-world implementation of procalcitonin testing within their ICU. And there's a group out in Ontario that took the SAPS protocol, implemented it in their ICU, paired it with twice-weekly stewardship rounds, and they were able to see a 27% reduction in their antibiotic use. So we know this test works. The question was, how do we successfully implement this within our facility? So what changes do we need to make so we can see the outcomes that we're desiring? So we provided feedback to our prescribers and gained some of their insights. We implemented once-weekly stewardship rounds, and then we tried to reinforce the procalcitonin protocol. And hopefully with the next round of data collection, we'll start to see things trend in the right direction. Okay, switching gears, we're going to talk about utility of MRSA nasal swabs in clinical practice. And I'd like to give a shout out to Karen Amekame. She is our pharmacy resident. This was her research project, and she created a lot of the slides I'm about to go through. So credit to her. So a bit of background, Staph aureus can colonize our nasal cavity and our nasal pharynx, or the back of our throat. And so when we're talking about methicillin-resistant Staph aureus, doing an MRSA nasal swab can help identify which patients are actually colonized with MRSA. And this is important because if we think about pneumonia specifically, for example, oftentimes the pathogens that cause pneumonia are usually pathogens that are colonizing our upper respiratory tracts. And so using an MRSA nasal swab can identify, once again, which patients are actually colonized with MRSA. And there's been some pretty large trials, retrospective studies out there, showing that MRSA nasal swabs have a very high negative predictive value in ruling out MRSA pneumonia, ranging from 95 to 98%. And in Regina, we calculated our own negative predictive value to be 97.4%, which means that if we do an MRSA swab and it's negative, there is a very, 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 very high chance that this patient does not have MRSA pneumonia. So 97% of the time, they do not have MRSA pneumonia. Adding to that, there are high quality studies that have shown that when you use MRSA nasal swabs to rule out MRSA pneumonia, you can reduce anti-MRSA therapy, specifically vancomycin. So that's fantastic. So this is a tool that we could use to help reduce vancomycin use or reduce anti-MRSA therapy. And so we had designed a residency research project around this idea. And Karen had created a presentation that she had distributed to the intensivists in the ICU group and the pharmacists. And she had conducted some polling questions just to gain some understanding around perspectives on barriers to this project. And then she created an MRSA swab protocol, which would identify which patients we would be ordering the swab in, and then how we would de-escalate therapy. And this was very much a pharmacist-driven tool to aid in the de-escalation of anti-MRSA antibiotics. So this is what our protocol looked like. It included adult patients admitted to the ICU with suspected or confirmed pneumonia, in which anti-MRSA therapy was either being initiated or being considered. And so if that patient met the inclusion criteria, then we would order an MRSA swab. And if it was negative, because it has such a high negative predictive value, we were recommending to either stop the anti-MRSA therapy, like the vancomycin, or not initiate it at all. And so we collected data around this. We obviously looked at our MRSA swab ordering rate per ICU pneumonia patient, pre-intervention and post-intervention. And this was after basically the education sessions that Karen had provided to the clinical team. And what we saw is after the education session, there was definitely uptake in MRSA swabs. So we saw an increase in physicians ordering MRSA swabs. So that was a good thing to see. And then in addition to that, what we also saw was a reduction in our anti-MRSA therapy, so specifically a reduction in vancomycin. Now, this wasn't a statistically significant finding, but we only collected data over a 3-month period. But definitely reassuring that we are trending in the right direction. And we're currently in the process of collecting data again, so hopefully we can continue to see that trend go down and see a reduction in our vancomycin use. Okay, the last initiative that we got going on in the ICU is our antimicrobial stewardship rounds. So how all of this got started. So as I said, we submit our data to CNISP. We got that data back, which showed we use a lot of antibiotics in the ICU, far more than other participating centers across Canada. So we basically showed this data to our ICU group. And the critical care division lead, Dr. Sprague, was like, okay, this is concerning. Like, we need to do something about this. Can we implement once weekly stewardship rounds? And we were like, yes, we can. That's a great idea. And so every Wednesday from 1 to 3:30, we have antimicrobial stewardship rounds in the ICU. It's a 30-minute session. We have our stewardship pharmacist there, so either myself or Kristin will attend. We have the ID physician on call. We also have the intensivist and the pharmacist that's covering each ICU attend. And we have 3 ICUs, so there's a lot of clinicians, and then often we'll have learners and residents that will come attend as well. And so it usually ends up being a pretty big group of people at stewardship rounds. Each patient who is on an antimicrobial is briefly presented to the group, either by the intensivist or by the pharmacist. And then there's discussion around how we can optimize their antimicrobials. And we've been collecting data around this. And so far, about 1 year kind of post-implementation, we've had 139 interventions with a 77% overall acceptance rate. Our top indications for intervention are bacteremia, intra-abdominal infections, VAPS, and CAPS. Often what we're recommending is either stopping antibiotics that aren't necessary, or narrowing the spectrum of activity, or shortening treatment duration. So we've been able to make a lot of interventions in our ICU patients, and so hopefully that starts being reflected kind of in the bigger picture in the data that we send off to CNIST. Some barriers and facilitators around this. So facilitators, when we started rounds, we didn't really start with a specific structure or standard format. We just said, let's just start it and let's see where this takes us and how it evolves. And just naturally, it kind of evolved into the current process that we have going on today. And it's just evolved kind of based on the needs of the ICU clinicians and the interactions that we've had. So that worked out well for us. Just basically having flexibility with what that looked like. We also had really good engagement from our critical care clinician leads. So the division lead of the intensivist, Dr. Sprague, the pharmacy lead of the critical care pharmacist, so Suzanne Len, and then all of our pharmacists, they've all been fantastic champions of these rounds, essentially. So that's been fantastic. That's been really great. Having a consistent meeting place and time has also been very beneficial. Everybody knows that rounds are Wednesdays at 1 o'clock, and so they can plan their meetings and their days accordingly. And then Kristin and I have developed pretty strong relationships with our ID physicians because we round with them on a regular basis. And we also have really strong relationships with our ICU pharmacists. So that's been very helpful to facilitate discussions and create kind of a safe work environment. Some of the barriers or challenges that we've identified, having a large audience can sometimes prevent more candid discussion. Uh, Sometimes when you are reassessing antimicrobial use, um, physicians might feel like they're in a bit of a hot seat, especially in front of a big group of people. And so at times maybe it could be a bit defensive, and sometimes that can prevent just having a more kind of natural discussion around how to optimize antibiotics. So we've talked about ways that we can try and make the group a little bit smaller, but just unfortunately, given how these have evolved, it's not looking like we're going to be able to reduce the size. And so it is what it is. Other barriers or challenges that we've identified is the follow through or the accountability. So for example, some of the interventions that we'll discuss on rounds won't always get implemented the next day. And so sometimes there's that lack of follow through. We haven't completed the audit and feedback session yet. We're still kind of going through that data, so hope to be done it soon, and then we'll be providing that feedback to the pharmacist and the intensivist ICU group. And then last, it takes time. We're slowly building the relationships between the intensivist group, and it takes time to build that rapport and build that trust. And so we're slowly building that over time. And that's all I got for you guys right now. And I think I've got lots of time left for questions or discussion. So thank you for listening. And yeah, I'd be happy to answer any questions.
We do indeed have time. So thank you, Mel, for that. I'll stop the recording.